Going 12:30, so we'll go ahead and get started. Thanks to those of you who have joined us today. Welcome to Project ECHO Geriatrics. I'm Kate Bennett. I am the medical director for Project ECHO and a geriatrician at the University of Washington based at Harborview. If any of you are joining us for the first time, welcome, and welcome to all of you. I mentioned just a couple minutes ago, but I acknowledge that for many of you, this is a day of big changes and excitement because it's match day for fourth-year medical students, which also impacts residency programs. So thanks for taking the time to join us on this very exciting day. We have a really great session planned today. We'll run it like we usually do. We'll start off with a brief didactic with a little bit of time for questions afterward, and then we will move to a case that we'll discuss all together along with an interprofessional geriatrics group of experts, and we appreciate everyone participating in that. That's where we do a lot of our learning. But I want to introduce you to our speaker today, who is speaking to us about a very important topic that we don't talk about enough, and all of us don't have enough training in, which is the care of LGBTQ+ older adults in primary care. Charles Hoy-Ellis, who is in the School of Social Work, who is with the Goldston Institute, and has been a long-standing investigator with the Aging with Pride study, and has done a lot of work to improve the health, both mental and physical health and well-being of LGBTQ+ older adults, is here to speak with us. So I thank you for sharing your deep expertise on something that is very important for us to all learn more about.
Well, thank you very much, Dr. Bennett. Thank you all for being here today. It sounds like it is a very busy and exciting day for you. I also want to thank Dr. Karen Fredrickson-Goldson. She's the principal investigator of all of our research units and the director of the Goldston Institute. I also want to thank all of my teammates at the Goldston Institute. It's amazing to be part of such a team that plays well, works well together. We just have a great time while we're doing this really important work. So the usual, this is my own views and does not necessarily represent the NIH because the NIH sponsors our research, and I have no relevant commercial disclosures. So we started with Caring and Aging with Pride in 2010. It was the first ever federally funded study of LGBTQ adults age 50 and older. We had 2,560 participants from across the country. That cross-sectional study was so successful that it's now become a longitudinal study. Aging with Pride, the National Health, Aging, and Sexuality Gender Study. We're in the 6th wave of collecting data from 2,450 adults in all 9 census districts across the United States. My particular niche, I'm also the director of interventions for underserved communities. Innovations in Dementia Empowerment and Practice and Action is our intervention for older LGBTQ adults with dementia. And then Age Pride, which is the hat I'm wearing today, that is our translational community unit where we take our research back into the community, such as I'm doing right now. We also have Wellness with Pride, which is a national study of looking at the impacts of COVID among LGBTQ populations 18 and older. And then we also have a global Pride study, 6 continents, 10 countries participating with LGBTQ adults around the world. So that part of the titles in the title, who will be there to care for us without judgment, isolation, finding friends, support, caregiving, and health are the biggest issues older gay persons face. So these are the exact words of one of our research participants. So really quickly, there's a lot of health disparities that we see, and health disparities are by definition socially driven, social determinants of health. So either economic, physical environment, or social environment that is actually driving these disparities. So in this particular study, we used 7 years of Washington State behavioral risk factor surveillance data. And you can see here we compared lesbian, bisexual women aged 50 and older to straight women aged 50 and older, and gay and bisexual men aged 50 and older to straight men aged 50 and older. And you can see here there's quite a few disparities. There's only 2 where we're actually better off. So gay and bi men are less likely to be obese and less likely to have limitations in activities of daily living. So specific to LGBTQ older adults, these social determinants of health have been characterized as minority stressors. So the minority stress model came out in 2003, the fully developed model. And it says that these LGBT people experience these minority stressors on top of the stressors that we all experience. So like the stressors of a graduate or a medical program, serious illness, the loss of a close relationship, things like that. But then LGBTQ people experience stressors on top of that the general population does not experience. So the most distal is actual discrimination and victimization. And this can be acute incidents, or it can be chronic conditions, kind of like the cultural atmosphere. This has been found to be a significant driver of health disparities among older SGM adults, and also why they may or may not access healthcare. I'll talk some more about that in a moment. There's also an additional stressor, and this is closer to the self, is anticipated rejection, particularly from people close to them. So friends, family, employers, things like that. So this is an additional chronic stressor. And then we have, out of fear of discrimination and victimization and fear of being rejected, many LGBTQ people will conceal their sexual or gender identity. In the short term, it's a great strategy for making yourself a less visible target. In the long term, it becomes another chronic stressor. And then the most pernicious of all is internalized heterosexism. So we all internalize society's dominant negative attitudes around different social identity groups. So I'm a big fan of The Wizard of Oz. And what this says to me is that these minority stressors will get LGBT older adults, and they get their health too. So that's what those health disparities are about. To really understand the LGBTQ older adults today, you also need to understand historical and social context. So the first edition of the DSM, which came out in 1952, characterized homosexuality by definition as a sociopathic personality disorder. People could be, and were involuntarily committed and involuntarily submitted to treatment to cure their homosexuality. That included lobotomy, castration, things like that. In terms of legal systems and politics, it was a federal offense in all 50 states until beginning in the 1960s, and in 17 states until 2003, same-sex behavior was a felony. Not only were people arrested and beaten, their personal information was published, and they typically lost their jobs, their families, and things like that. So out of all of this, we developed the health equity promotion model. So my particular interest, I'm also a licensed clinical independent social worker, and have 20 years experience working with sexual and gender minorities. So when someone comes in to see us, they typically come in for mental health issues or physical health issues. And typically, these are some of the places that we look at. So, what's your diet like? What's your exercise like? What does your social support system look like? We tend not to look so much at these other issues. What we typically do not look at are the structural and interpersonal contexts. So this is where the discrimination, the victimization, the marginalization, the isolation, all of that happens. And this is driving both directly and indirectly through these adverse and health promoting pathways, these health disparities that we see. We also typically don't account for intersectional social positions. And this is important because the more marginalized social identities a person has, the more types of discrimination, the more intensive discrimination, and the greater the impact of that discrimination. So a Black transgender lesbian woman is going to experience racism, cisgenderism, sexism, and heterosexism, while myself as a white gay man, I'm only going to experience heterosexism. We also incorporate a life course perspective, because we know that what happens to you earlier in life is going to affect you later in life. This is where you come in, because we all have implicit bias. When I teach in formal settings, I tell my students the best way to piss me off is to tell me that you're going to leave your biases at the door, because the only way you can do that is to physically detach your head and leave your head at the door. And these implicit biases, we're not conscious of them, and they can actually influence what we perceive, how we perceive it, and how we explain it. So I'm going to say a little bit more about this in just a moment. So going back to that long-term concealment. So our research shows that 1 in 7 LGBTQ older adults fears accessing healthcare services. 1 in 8 have been denied outright or provided inferior healthcare services. 1 in 5 are not out to their primary care provider. So think about this historical context where the medical establishment pathologized and criminalized these people. And so you don't just forget that. And we all do. Myself, I've been doing this work for more than 20 years, and I still have implicit biases. For yourselves, not disclosing your sexual orientation or gender identity may have serious health consequences for your patients. So this is from a study where both trans people and physicians acknowledge that their physicians' lack of knowledge was a barrier to trans healthcare and can result in not only denial of care outright, but also providing inferior care. That might just explain, so this is the findings from another study that we published just this past year. So we compared lesbian, gay, bisexual, cisgender adults age 50 and older to transgender older adults age 50 and older on their usage of recommended preventive health care screenings. So these are healthcare preventive screenings recommended once you hit the age of 50 and above. Of the 8 indicators that we looked at, you can see here there are significant differences. Transgender older adults are significantly less likelier to access these preventive healthcare services. We don't know for sure why yet, but we're fairly confident in saying that some of that discrimination, that victimization is part of it, as well as being treated poorly when you go in. I myself, I'm good with being gay, but I still have experienced implicit bias in healthcare settings. So I invite you to go to the Project Implicit. This is an ongoing study curated by Harvard University, and it doesn't tell you that you're racist or sexist or anything like that. It will tell you you may have a slight propensity to prefer one group of people over another group of people. One of the ways that you can make your place a more welcoming place and show that you are aware of the issues of LGBTQ older adults is to represent the full spectrum of these people, especially in outreach materials in your common areas in your offices. So if I see any of this when I go into your office or your waiting room, I'm going to know that you recognize that I exist and probably are going to be good to me. If you treat everyone the same, you're not treating everyone the same. You wouldn't give a 4-year-old girl the same dosage of a prescription that you would give a 40-year-old man. So that's the difference between equality and equity. Equality is everyone gets the same thing. Equity is what they need. So use more inclusive language instead of saying, tell me about your parents or your siblings. Who do you consider to be your family? How do you identify in terms of gender? And educate yourself and other service providers. There's a ton of books, ton of movies, ton of community events, and Seattle is one of the major places of LGBTQ support and services. If someone does come out to you, do not respond with neutrality or negativity because you're saying it's not important. Do not misgender people. You might be the first person that this person has ever come out to, and that is an incredible honor. So in closing, this is also a quote from one of our participants. In spite of some of the hassles I've had in my life because I'm gay, I consider being gay a gift. It's made my life richer and opened so much of the world for me. Of course, if I had to do it over again, there are some things I would do differently, but being gay isn't one of them. I absolutely agree with this. So with that, I'm going to say thank you. This is the, if you want to check out our website or anything like that, this is my personal contact information. Feel free, and thank you all very much. So I think we have time for maybe a question or two.
Thank you so much. There is so much work to do. And thank you for sharing that presentation. If anyone has questions, feel free to unmute, or if you're not able to unmute, you can put them in the chat.
Thank you, Tony.
I guess I have a question. It
Okay.
feels, because it's a very personal thing, talk that you've given, it sort of feels personal to even say it and you'll see. We'll see. I think it will imply implicit bias. So I know I have implicit bias and I'm about various things, not, actually not, I don't think about one's being gay or not gay is that, but I know I have implicit biases. So what do you do besides introspection and reflection to help change that? I mean, is it literature? Is it art? Is it none of those?
Well, thank you for that, Barbara. It's a very important thing, and I don't know if I have time to give a full answer here, but I'll do my best. The most important thing that you can do is recognize when you are in the midst of actively, implicitly biasing someone, because we're actually hardwired. It's nothing to be ashamed of. We are socialized this way, and it's part of our evolutionary a way of how we've survived. You know, we can't sit there and get to know a lion to find out if the lion's going to eat us. But if you can recognize, oh, I'm stereotyping this person, and you can cognitively replace that stereotype with something that's opposite. So I'm getting ready for another talk in a couple of weeks, and I'm going to ask, so how many Black rocket scientists or famous medical people do you know? One person might be able to mention Ben Carson, but I have a whole slide of others who have really changed the world. And so when you catch yourself stereotyping, you can take an image and replace that image with an image that kind of counters that stereotype. Immerse yourself in different cultures and different social groups, get to know people. Yeah, and it's a lot of work. And like I said, I've been doing it 20 years. I think I'm better than I used to be, but I still have implicit biases.
Thank you.
You bet.
I'll put a little comment here. It's sort of, I might as well not because I can't type and say thank you. So it's sort of like trying to reframe in the moment and sort of like, you wake up and you say, oh, I really don't want to do work today. And then try to remember why you do want to do work.
Exactly.
Okay.
And it's like
helpful.
It's like medicine, it's like nursing, it's like social work, anything else. It takes practice. The more you do it, the more automatic it becomes. And it's kind of like the art of racing in the rain.
Oh, I love that movie.
Yeah. So when you're first starting to drive, you have to think about every movement that you're making. The more you do it, the more it travels back in your brain until you're not even thinking about what you're doing. So it's that same kind of paradigm.
Thank you.
Yeah. Thank you, Barbara.
Well, I know you have to head off to another meeting, so I don't want to make you have to actually race in the sun, but I really, really appreciate the time you took. I think the recording of this talk is going to be watched quite a bit, and please pass it on to your colleagues once that's up and posted. I think that I'm just so very grateful that you came and spoke to us today.
Thank you again, Dr. Bennett, and thank all of you. And again, please don't hesitate to reach out to me if you have any questions or anything. Y'all have a great day, great weekend, and good luck on your matching, whatever that is. No clue. Take care. Bye-bye.